Morning, everyone. Hello, hello, hello. I am Dr. Colleen Morley. I am, as Doug said, the current national president of CMSA, and want to honor and joy and what a great ride it's been so far. Just want to tell you a couple of things that we're doing with the national organization, letting you know what's going on. If y'all know me, I'm really not a very formal speaker. I'm an educator. I like to teach, and my style is very collaborative and very informal. So just want to let you know, if you're not a member of CMSA, we are the oldest professional organization for professional case managers and the case management community. So you don't necessarily have to be a case management nurse, social worker, physical therapist, disciplined professional to be a member of CMSA. You can be a case management community member, just like our friends at Encompass or Chefs for Seniors. This morning, all are welcome because it takes a village to do the work that we do. Let's see. And it's also across the continuum of care. You saw that I have been involved with the American Association of Managed Care Nurses. Yes, absolutely. I'm also a member of several other professional organizations, but I found that CMSA is the one that brings everybody together at the table. And that's what it's all about, is working across that care continuum for the best interest of our patients. A couple of things going on at CMSA National. Exciting times, guys, exciting times. Right now, we've got our member get a member program. So if you are a member and you refer somebody to join, make sure that they put their name down on their application form when they're typing it into the computer, and you will get credit for that member. And the member who recruits the most members during this time, I believe it goes through April, will receive a free conference registration for the national conference in June. And yes, conference registration is open. So jump in there, get that early bird rate, but most importantly, make your reservations at the Mandalay Bay, because that room block is going fast. Second thing that's going on, we have a strategic plan, and it's EPIC, EPIC. One of the C stands for collaborations. And so this year we are really focusing on launching our collaborations committee, which will be coming up shortly, with a focus on collaborative efforts across academia, because, hey, let's face it, nobody teaches case management in any discipline school, right? Regulatory, working with regulatory agencies, such as you've seen that we're collaborating with the NQF by Becky Perez, being on their committees and working with them and putting out incredible work. I'm working currently with the QIO, QIN to create a collaboration there. So lots of collaborations that we can impact not only policy, but also what happens with our patients across the continuum of care. And then also community collaborations, what's going on in the communities that we can collaborate with larger entities to bring all of that knowledge and all of those resources together for you to be able to serve your patients. So that's number 2. That's very exciting to me because I'm all about collaborations. And number 3 goes back to membership. We're, as Maureen and Doug spoke earlier about, we're doing a collaborative education program for some case managers from Singapore. We've also got some collaborations going on with several case management professional associations in Africa and Europe. And then also we're looking at helping to launch a case management chapter in Saudi Arabia this year. So lots of interesting things going on. There's lots of mergers and, big, gigantic things going on here in the US as well. So stay tuned. You're in the right place, because this group is going nowhere but up. All right. So that being said, I'm taking off my president hat and I'm putting on my educator hat. And let me go here and I will share my screen. All right. Hopefully everybody can see my screen. Beautiful, beautiful. All right. go from here. All right, so my first presentation today is the Hospital Readmission Reduction Program Revisited. I first did this presentation at the CMSA National Conference last year, and it was a very interesting program to research because let's face it, we live every day, day to day, with this whole concept of trying to prevent readmissions that sometimes we kind of get lost in the why we're doing it, right? So I decided I was going to go back and look at the whys we were doing it and all the little milestones that happened across the 10 or so years that we've been focusing on this. And then what's actually come of it? Or what's the research saying that, the outcomes, the risks, and the benefits of readmission reduction strategies. All right, so my standard disclaimer, there are no potential conflicts of interest in this information. All material is either my opinion or cited to source and or authority. And any products that are referred to during this presentation are for the sole purpose of example and are not recommendations or endorsements. So we all know that there's been a focus on readmission reduction and prevention in acute care facilities since about 2009. We know that potentially preventable readmissions are related to or defined by as being related to a failed or ineffective discharge plan, especially for our patients that have chronic high focus diseases, the ever popular congestive heart failure and chronic obstructive pulmonary disease, of course, were our starting points. So as a nurse, as a disciplined professional, that's on day one of nursing school, this teacher, very imposing lady, about 6 foot tall, long red hair down to her waist, stood up in front of us and did not say, "Welcome, we're so glad you're here. Welcome to nursing." She stood up there. The first words out of her mouth were, "Discharge planning begins on day one. Know it, live it, love it." And we all went, "Oh no, what have we done?" So as a nurse, discharge planning begins on day one. Potentially preventable readmissions are defined as related to a failed or effective discharge plan. I kind of take that personally. So with over 10 years of work that we've invested in hospital readmission reduction, I've really felt, like I said, this is a great opportunity to kind of take a look back and figure out, okay, are we continuing to do things? Is it activity with no benefit? Is it activity with no result? What are we doing about this? Because we've seen in your own areas, in your own hospitals, maybe your readmissions are going down in certain categories, maybe they're going up in certain categories, but as a whole in the nation, as you'll see, there's not been that big of a discharge or big of a readmission reduction over the past 10 years. So the question is, what are we doing? Why are we doing it? And how can we do it better? So I took the opportunity to look back at the literature, take a look at some evidence-based practices that are related to those readmission reduction activities. And that's what this is going to take a look at. We're going to explore the history of the HRRP. We're going to look at some current practices that are out there to reduce readmissions. And we're also going to take a look at it from the risks and benefits perspective for patients and the healthcare system as well. Okay, our learning outcomes are: you will be able to identify key events in the history of the HRRP and the reason that we are focusing on readmissions. You will be able to explore the readmission reduction outcomes and evidence-based practices surrounding readmissions from 2009 to current date. And we will examine topics and concepts that are associated with the risks and benefits identified in the literature related to HRRP initiatives. So the readmissions reduction journey. How many of us in this virtual room have something to do with readmissions, or we think about readmissions every day at our workplace? Put your hand up in the chat or whatever. So the HRRP is, by definition, a Medicare value-based purchasing program that encourages hospitals to improve communication and care coordination to better engage patients and caregivers in discharge plans, and in turn, reduce avoidable readmissions. So a lot of communication, a lot of education, and a lot of care coordination with the focus of patient and caregiver engagement. Okay, keep that in mind, because you'll see a lot of things are very, very education focused that we've been doing. We've got a lot of care coordination going on, but I'm not really sure if the patients are more engaged now than they were then. The program also supports the national goal of improving healthcare for Americans by linking payment to the quality of hospital care. And again, this is, we'll talk about that later. Jasmine tea, yum, yum, yum. Okay, so what is a readmission? When we first started on this journey, oh my goodness, it was a ping pong ball of that's a readmission, that's a readmission, that's a readmission. We needed a definition, and the definition kept bouncing around too. It was at first, I thought, okay, we're only looking at CHF and COPD readmissions, and we're only looking at the readmission for CHF back into the hospital for CHF. Well, we found out very quickly that that was not the case. Hospital readmission is defined as a patient who's been discharged from a hospital who is admitted again, not just to the hospital that they just got discharged from, but to any acute healthcare facility within a specific time frame. And it can be for any reason. So you've got a CHF patient that you're discharging home to their house, and they get into a car accident on the way home and they get admitted into another hospital across town. You don't even know about it. That's a readmission. The original hospital stay is referred to as the index admission, and the subsequent hospital stay is defined as the readmission. The most common timeframes that they look at for research purposes are 30-day, 90-day, and 1-year readmissions. Now, 30 days, we all know we've got the penalties for those. They've been saying that they're going to be going to 60 and 90-day readmissions. That still has not happened yet because we really haven't gotten a handle on the whole 30-day readmissions yet. But then there's some impact of a 1-year readmission as well, and we'll take a look at that information too. So CMS includes the following 6 conditions or procedures in the 30-day risk of standardized unplanned readmission measures. So it started out with acute myocardial infarction, chronic obstructive pulmonary disease, heart failure, pneumonia, and coronary artery bypass graft surgery, and then elective primary total hips or total knees arthroplasties. And why isn't this working now? Okay, make it work. There we go. So why are we looking at readmissions? You know, what's the big deal about it? You know, back in up until 2009, it was, you know, we were concerned about heads in beds, and, you know, didn't matter how many times a person had to come back to the hospital to get tuned up for that issue. We were there for them, and we still are there for them, but we really do have to take a look at it, because readmissions within the first 30 days of discharge for a same or similar diagnosis are considered potentially avoidable admissions, because what happened that they're in the hospital, you tuned them up, you sent them home, and there was a failure of the plan for them to take care of themselves after that. And again, it's a perception of a failure of a discharge plan. What didn't we do to make sure that our patients were equipped to take care of themselves? Now, in addition to the financial risk, readmissions are now publicly reported as a quality metric, and they impact the facility's Medicare star rating as well. So, you know, those two things have a lot to do with the financial health of an organization too. The financial implications continue with penalties that are levied on facilities with higher than average rates of readmission. And then admissions that are identified as readmissions will not be reimbursed. So you're getting a double whammy there of, okay, patient came into the hospital at the beginning of the month, they were readmitted in the middle of the month. Okay, you're going to get paid for that first admission. You're not going to get paid for that second admission. If they come back a third time within that 30 days, you're not getting paid for that one. Oh, and then at the end of the year, Medicare is going to take a look at your average rate of readmissions. And if it's higher than this, that, or the other, then they're going to penalize you up to 3% of your Medicare reimbursement, not just your Medicare reimbursement for that particular diagnosis, but your facility's overall Medicare reimbursement. And that's a lot of money, guys. So you get the whammy of not getting paid for the admission, and you get paid for the admission, you don't get paid for the readmission events, and then you get penalized for it on the back end as well. So how did this start? Well, we started by talking about it back in 2009, and then they got around to actually establishing revisions. They defined what a readmission is. Remember I said we started talking about it in 2009. Oh, what's a readmission? 2012, they finally did define what they were looking for in a readmission. They established those initial diagnoses of congestive heart failure, AMI, and pneumonia, and then established the readmission ratio calculation, sorry for the typo, from the NQF, and set a 3-year look back period for eligibility establishment. So they said, okay, in 2012, we're going to look back 3 years. So that was what, 2009. And we're going to take a look at what your average readmission rate was. And that's going to be your baseline. And we're going to tell you that you need to improve from there. In 2013, they defined which hospitals were subject to the HRRP, and then they established a methodology to calculate that payment adjustment and establish the preview and the corrections process for data submission, because we have to have an opportunity to appeal the decisions that they make. 2014, they added COPD, hips, and knees to the diagnosis list. In 2015, they added cabbages to the diagnosis list. In 2016, I thought this was interesting. They adopted what they called an extraordinary circumstances exemption, meaning that if a force of nature happened, fire, flood, et cetera, a big IT shutdown, your whole system went down, you could apply for an extraordinary circumstances exemption for a certain period of time, to have that period of time pulled out of your readmissions calculation risk. Very interesting. And that really did come about because there were a couple of hospitals that faced some extraordinary circumstances that impacted their ability to take care of their patients and properly prepare them for discharge. In 2017, they facilitated a process for public reporting as soon as possible after the review period. So before 2017, it wasn't even really publicly reported. Patients would ask you about your readmission rate if they were savvy, and you could give them yours, based on your internal information, but you really didn't have access to the external information. And the Pepper reports, if you're familiar with those, come out on a delay. So you're looking at the information, kind of in almost a 3 to 6 month delay. So our readmission rate 6 months ago was this, not really good with real-time stuff, but then your own internal calculations are only for the patients who readmit to your facility. So you can't even figure out who's going to other hospitals in your area until you get your Pepper report. And then your number from your internal doesn't jive with your number from your Pepper report. And you're like, externals, got it. In 2018, the 21st Century Cares Act put in some changes and established benchmarking for dual eligible patients starting in fiscal year 2019. Major thing. And then, of course, they updated that extraordinary circumstances exemption to include data system issues at this point in time. In the 2016 iteration of it, they did not speak to data system issues. Now in 2018, they're like, yeah, that can cause some stuff too. So we're going to throw that in there too. 2019, they finalized the definitions. 2012, they started defining. In 2019, they started finalizing the definitions, especially related to the dual eligible population. What's the proportion of the duals that are responsible for different pieces of the payment, and the applicable period of dual eligibility. We also looked at aligning with the meaningful measures beginning in fiscal year 2020, and the 6 readmission measures were going to be removed from the hospital inpatient quality reporting program. So they took the 6 diagnoses out of the hospital inpatient quality reporting program, because then hospitals have the risk of being penalized twice, and that's double dipping, and that's not cool. So they did realize that, we're going to pull those out so that we don't penalize twice for basically the same thing. Starting in 2019, CMS also takes into account the proportion of low-income patients within a hospital, since they are more likely to be readmitted due to other socioeconomic factors. And we'll see that a little further into the presentation as well. In 2020, they updated the dual eligible calculation proportions to be effective in fiscal year 2021. And then in 2021, they adopted applicable periods for fiscal year 2023. And that pretty much brings us up to date with the revisions timeline of the HRRP. Now, I did, however, because I like visuals, make you a pretty little timeline for this so that you can go, that's what happened, where, and what. All the same information, just organized a little differently and much easier to read. So in fiscal year 2022, from the 3,046 hospitals that Medicare assessed for hospital readmissions, 2,499 or 82% were penalized for readmission rates exceeding the 30-day risk standardized readmission rates. This is in 2022, okay? This is only slightly lower than in 2015, where 2,610 hospitals were penalized. So that's 7 years. Look at the graph. Are we making progress? I mean, we went from 2,600 in 2015 to 2,400 in 99, so 2,500 hospitals in 2022. The progress is incremental. I mean, it's very slight. And this is one of the reasons I really wanted to take a look at this whole project and this whole program, because we have to realize too, and I'm going to stop, my formal presentation right here. So here's my theory of why these readmission rates don't move. My theory is this is not a static population, okay? If you take the group that we started working with in 2009, it is now 2023. So 14 years, yeah, about 14 years. You've got patients who were diagnosed in probably stage 2 CHF. We'll use CHF as our benchmark. Stage 2 CHF in 2009. It's now 14 years later. They're probably stage 3, maybe even stage 4. So are we only looking at that population that we started out with in 2009? The answer is no. We're looking at everybody who got added into the mix from 2009 forward. So you have your stage 3, 4 patients that you started out working with in 2009 that have heard everything that we've got to throw at them. And they're probably really good about managing their care, but now they're in stage 3 and stage 4. So they're probably experiencing increased exacerbations and, because it is a chronic condition. But the patients that are coming in the hospital today with a new diagnosis of CHF have not heard everything that we have to throw at them. They have not had the time to adjust to this new diagnosis. They're going to be coming back to the hospital over and over again because they're just not quite sure yet. They're unsure of how to take care of themselves. They're nervous about taking care of themselves. They may be in denial about taking care of themselves or even having this diagnosis now. So yes, they're going to keep coming back to the hospital. One of the hallmarks, one of the key moments that I had in readmission reduction, I was working at a hospital on the south side of Chicago. Hold on one sec. Patient kept coming in. She was probably admitted within a 3-month period, probably in the hospital about 12 times. So I went into her room and I said, we really need to talk about how you're taking care of yourself at home, with your chronic condition. And she just looked at me. And I said, well, your congestive heart failure. She goes, oh, yeah, that. I said, so, what's the problem with, where are you finding issues with trying to manage your condition? She goes, I don't have a condition. She goes, I have this, and I keep coming back to the hospital because you didn't cure me. No one had told her what a chronic condition is and that she was going to have this now for the rest of her life and that there was no cure. There's only treatment. So that whole mindset for her needed to be changed, but nobody had addressed that. So really getting into the whole concept of lifelong condition, it's treatable, we're going to help you with this, and moving the patient along the continuum of care and helping and supporting them was not a concept that had been addressed with her. So we have those patients. Then we have patients who, like I said, who come in and it's not the same group of patients that we were working with in 2009. This is why this doesn't move. Our readmission rates are moving like this because we're not talking to the same group of people over and over and over again. It feels like we are, but we're not. That makes sense? I hope so. That's my theory about why readmission rates are not moving lower, because we're not talking to the same populations. So let's take a look at some outcomes from 2009 to present. So 2013, 1 out of 5 19.8% of Medicare patients were readmitted within 30 days. 34% of them were readmitted within 90 days. 61% of patients who were discharged with medical conditions were either rehospitalized or died within 1 year. 51.5% of patients who were discharged with surgical conditions were either rehospitalized or died within 1 year. And 50.2% of patients who were discharged from the hospital did not have a PCP visit within the immediate 30-day post-hospitalization period. And we all know the gold standard is 7 days, right? Here's our statistics for 2021. 15.5% of Medicare patients that were readmitted within 30 days. 19.8. 30% were readmitted within 90 days, down from 34%. 39.7% were readmitted patients die within the first year of admission, with the first readmission. 35% of patients hospitalized with pneumonia or readmitted died within 1 year of discharge. And then 48.8% did not have a PCP visit within the immediate 30-day post-hospitalization period, down slightly from 50.2%. But that's abysmal. That's sad. That's my own opinion. Just gonna put that out there. All right, our statistics overall, Medicare all-cause readmissions, 2017 to 2019 reporting period demonstrates a 15.5% readmission rate. So in 2010, we were at 18.3%. In 2014, we went down 1% to 17.3. And in 2019, we're at 15.5 for a total decrease of 2.8% for Medicare readmissions between 2010 and 2019. 10 years of work. And we only brought it down by 2.8%. And again, is it because we're not dealing with a static population of people? So why are we focused on this? Well, number one, the number of people with chronic conditions is rising. Take a look at the graph on your left. 1995 to projected 2030. So in 1995, we had 118 million people that had chronic medical conditions. In 2030, it's projected to be 171 million people with chronic conditions. Chronic medical conditions are things that people have that, we can treat, we can work with them, but they have to be engaged to do it as well. From a cost perspective, acute hospital readmissions, $26 billion in Medicare spending in 2019, $29 billion in Medicare spending in 2015 for the $26 billion, and 2019, $29 billion. According to CMS, that population is predicted to rise. We saw that graph on the side. And in 2019, 82% of hospitals in the HRRP received readmission penalties, which is only down slightly from 2015. Now, some examples using our ever popular CHF and COPD for costs of care. 2012, the readmission rate for CHF was 34%. In 2019, it's 21.9. Taken as a snapshot, just CHF, looks like CHF's doing pretty good, right? Then you look at the costs of care. 2012, $65 billion. We brought the cost of care down in 2020 to $43.6 billion. But in 2030, if we don't do something about how we're helping patients manage their CHF, we're projected to spend $69.7 billion on CHF readmission care. Now, COPD, 2012, readmission rate 27%, 2019, 19.7%. Again, doing really good if you're looking at COPD as a snapshot. In 2010, we spent $32.1 billion, and in 2020, $49 billion. So went up with a 52.6% increase in costs of care over 10 years. All right, now let's take a look at all the great work we've been doing out there. So CMS QualityNet, if you go on QualityNet, they've got a lot of great resources. I apologize if you can hear my dogs right now. Give me a second. Sorry, they go nuts when people wake up and come down the stairs. Okay, so CMS QualityNet has a lot of great resources and databases available. If you click on any one of them where they say view, go on QualityNet, you'll find a whole bunch of different projects that are available for readmission reduction. I used this article as a basis of my first part of my electronic road trip article in CMSA Today. The National Priorities Partnership, the Commonwealth Fund, Project Red on the bottom, and Interact are actually programs that you can put in place at your facilities, which I'm pretty sure everybody's familiar with both of those as well. The Community-Based Care Transitions Program, same thing. You can go and put that right in place. Patient safety organizations, we're going to talk a little bit more about it in a little while. These are great organizations to get involved with or to start programs at your facility. Highly underused resources. Take a look at them, pack a lunch, spend the day. All right, now it's not working again. Got it. All right. So patient safety organizations. These were created in 2005 under the Patient Safety and Quality Improvement Act. Part of it is voluntarily reporting your quality and patient safety data from individual providers and healthcare organizations. It's not meant to be a punitive thing. The goal for them is learning and creating solutions. So your facility reports this data, it becomes a database, you can see what's going on, you can benchmark against other facilities, et cetera, et cetera. In 2019, they did a survey and they found that over half of the acute care facilities that were voluntarily working with the PSOs, 80% of them said that the feedback and the analysis on the patient safety events that they reported have helped to prevent similar future events, and avoidable readmissions fall into the patient safety. So why do hospitals value them? Well, 2/3 of the hospitals said that the PSO analysis gave them measurable improvements in patient safety. 2/3 of them said, hey, this worked great for us. And we were able to create improvements to address patient safety. Hold on one second again. Sorry, they're insane. All right, so there are 8 patient safety activities that are carried out by or on behalf of a PSO or a healthcare provider. The first is to improve patient safety and the quality of healthcare delivery. So if readmissions are a failure of a discharge plan, that is a healthcare delivery issue, correct? So and if patient safety and readmissions are coming together, then we need efforts to improve both patient safety and the quality of the delivery of healthcare. The collection and analysis of the patient safety work product. So everybody putting their information into this big bucket and having it analyzed and assessed, et cetera, really does help us to get the information about what people are doing, what challenges are they facing, and sharing similar circumstances and similar experiences. This worked for us. It might work. It might not work for you, but hey, it's out there. And that's part of the problem with a lot of the research that we do is that we don't consider it research. Number one, oh, it's a process improvement project, but hey, guess what? That's research too. But we tend to keep it to ourselves. Oh, it's just, it only works here, or it didn't work so great. But if it didn't work so great, it might not work so great at your place, but it might work really well someplace else with a different population. And a lot of these process improvements and a lot of these great ideas languish in a folder on your desktop or literally printed out on your desk looking like this, and they just sit there and they don't get out into the ether so that people can say, hey, that's a great idea. We don't have to necessarily recreate the wheel. Let's just take this and adapt it for our population. So getting that information out there is a key to a patient safety organization. The development and dissemination, that's what I'm just talking about, dissemination. We have to get the work out that we do. Recommendations, protocols, information about best practices. Journals are important. I mean, that's a great resource, but how much of the work that we're doing actually ends up in a journal or a magazine? We need to get it out there, guys. Utilization of the patient safety work product for purposes of encouraging a culture of safety, as well as providing feedback and assistance to minimize that patient's risks. And again, since readmissions fall into patient safety, we need to be able to utilize this information to effectively help minimize the risk for our patients. And how do we do that? Through education, through supporting them, through making sure that they understand what the risks are that they're facing. And the maintenance of procedures to preserve confidentiality with respect to that patient safety work product. So instead of just throwing everything into a bucket and letting everybody do it, there's somebody there maintaining it and making sure that patient privacy is protected. We are also, or PSOs also provide appropriate security measures with respect to the patient safety work product. They utilize qualified staff as well. And the activities that are related to this operation of the patient safety evaluation system and the feedback to participants. So it's not just a one-way communication, it's a bi-directional communication. So what you're putting into it, you're also getting out of it as well. So they maintain all of that too, instead of you having to create a wheel in your facility that is going to go out and grab information and then come back in and give it out. It's all done for you there. So getting involved with your PSOs in your areas is hugely beneficial. AHRQ, one of my absolutely favorite places to spend a day. I've been known to actually take a day off of work and sit home and surf on the AHRQ website. But these are some of the resources that are out there specifically for readmission reduction. And it's not just hospital facing. You've got your AHRQ hospital guide to reducing Medicaid readmissions. You've got the re-engineered discharge toolkit. So you've got toolkits out there. That's the Project Red one. Project Boost is on the bottom in the blue. On your right-hand side is the Health Literacy Universal Precautions Toolkit, which I will talk more about in my second part. But then there's also on your far left, Taking Care of Myself, a guide for when I leave the hospital. That is patient-facing. Now, how many patients do you know are going on AHRQ? Probably not a lot of them. But I think it would behoove us all to go on to AHRQ, pull this off, take a look at it, and figure out which parts of it we can use for our patient education. Okay, so then we have comprehensive case management programs. These are models of care coordination that have been shown to demonstrate the most impact on reducing readmissions for our target populations. They feature the goal of using a holistic approach to develop collaborative and interdisciplinary teams to facilitate patient self-management. I cannot stress this more. The goal of the hospital readmission reduction is to empower our patients to be able to self-manage from the time of admission through that defined post-discharge time. Okay, so we get them out 30 days. Yay for us. They didn't get readmitted within 30 days and they come back on day 31. Is that a success? Kind of, but not really. They got through 30 days, but what are we going to do when it moves to 90 days? We've got to move the ball from helping them self-manage from the time of admission through post-discharge, through that 30-day post-discharge, to making sure that they can take care of themselves until the next crisis comes up where they're out of control, and limiting the amount of those crises periods as well. These also include vital interventions that are just not included in the standard discharge process. We all know what the standard discharge process is, and it varies from place to place, and it's pretty flawed. I mean, I remember being in the hospital. I remember getting ready to be discharged, and the nurse is sitting there going over everything with me, and I'm just like, where do I sign? I'll read it when I get home. And chances are you're probably not going to read it when you get home. So we have to make sure that we are including interventions throughout the length of stay and taking advantage of the opportunities that we have with the patient being there in the hospital with us as educational opportunities to be able to help them understand how to manage their care at home. We have to do an assessment and evaluation of a patient's available social supports, and maybe the need to restructure that discharge process to eliminate the fragmentation and communication breakdowns that we all know are the top priorities of this. So to answer that, some of the top strategies do include consistent use of continuous medication reconciliation at each level of care, hospital to whatever post-acute they're going to go to, if they're skipping over post-acute, to the PCP and then back, and then making sure that all of that is taken care of. Use of standardized tools and patient education across the care continuum. Nothing more frustrating than a patient getting a packet of information from us in the hospital and then going to their PCP and getting a completely different packet of information that doesn't really say the same thing. Active coordination of follow-up appointments, including making and confirming follow-up appointments prior to discharge. 50.2% of patients back in 2013 left or did not make their follow-up appointment, did not attend a follow-up appointment within 30 days. And it only went down to 48% in 2019. So not only of making and confirming, but hey, stressing to them that this is important and you got to go. I have a great anecdote about that one too. Asked a patient, why they didn't go for their follow-up appointment. And she said, I just saw a whole bunch of doctors. Why do I need to see another one? It's like, well, you might want to go see this one because it's important. It really took quite a bit of a conversation to have with her to make her understand that, the doctors that took care of her in the hospital were not the people that were going to be managing her care outside of the hospital. And she needed to go and see that guy so that we could close the loop and make sure she was supported. Making contact with the patient 48 to 72 hours post-discharge to review and reinforce the discharge plan to increase the communication needed to effect a successful transition. I'll tell you all about my other guy later. So early days intervention. We took a look at the evaluation of readmission impact. In 2006, a project was done out of Carolinas Medical Center in Raleigh, North Carolina. They followed CHF patients from admission through connection to post-discharge resources using a multidisciplinary team approach and included referral to a home health program that followed the patients for 6 weeks after discharge, assessing, educating, evaluating, and identifying early intervention opportunities, catching readmissions before they could happen. And readmissions decreased from 18.2% to 11%. And that was back in 2006. So that's 17 years ago. Or my math is bad. The study did demonstrate, however, that a structured care continuum development by specifically trained professionals created a measurable reduction in readmissions. And the patients reported an increased quality of life because they weren't back and forth and back and forth and back and forth to the hospital. In 2015, Glazer and El Haddad reviewed the risk for readmission for patients discharged without post-acute services and said that the incidence of readmission was over 30% higher in the discharge to outpatient follow-up than it was for the population that were actively linked to post-acute services or follow-up. So if you're discharging your patient home with absolutely no follow-up and here's an appointment, I hope you make it, that those patients are 30% higher at risk of readmission. Community-based transitions programs. Now, under CMS Innovation Center, which is also a really cool place to visit if you have a day to just chill, started in 2012 with 17 partners. Ran for 5 years. Participants were awarded 2-year agreements that could have been extended annually through the duration of the program, dependent on their performance. And these community-based organizations used care transition services to effectively manage their Medicare patients' transitions and improve the quality of care. It was funded from 2011 to 2015 with up to about $300 million in total funding was available. And these CBOs were paid an all-inclusive rate per eligible discharge based on the cost of the care transition services provided at the patient level and implementing systemic changes at the hospital level. They were only paid once per eligible discharge for 180 days, and they decreased costs for inpatient nursing home and observation costs. But they did notice an increase in home health care costs, but they did decrease readmissions by 12.92%. I was involved with one of these programs at a previous employer. We were connected with them, and the work that they did in collaborating with the patient actively and providing, they went above and beyond. They put everything and the kitchen sink into these programs. home social work visits, and maybe if the patient didn't have a ride, they'd arrange a ride. Sometimes they'd go to the follow-up appointment with the patient with their permission and kind of act as their advocate. Great programs out there. Again, I mean, they're a little costly, but they do decrease readmissions. Other evidence-based practice review, comprehensive case management programs, CTI program, care transitions, showed that in their data, 13.8% readmission rate in the control group versus the 8.9% readmission rate in the study group. That's a significant drop right there. You've got Project Red out of Boston University Medical Center. This is really, I was involved in an iteration of Project Red as well. Patient education, advanced preparation for discharge. Project Red, and this is why it's been adopted by AHRQ as a best practice. It's sustainable. It's got a proven track record. Initially, they reported readmission rates decreasing from 24% to 16% on average. That's a huge drop in readmission rates. So, and Project Red is a whole program of great stuff, and you can get the toolkit on the AHRQ website. Project Boost, again, also available on the AHRQ website. Screens for 8 Ps: problems with medication, psychological, principal diagnosis, physical limitations, poor health literacy, patient support, prior hospitalization, and palliative care. And Boost reports a 21% reduction in readmissions overall. Take a look at that one. Interact is also on the AHRQ website. Interventions to reduce acute care transitions. Now, this is specifically focusing on transfers between post-acute levels of care and hospitals. So those readmissions from skilled nursing and from home health care. Really looking at improving identification, evaluation, and communication regarding changes in the resident status using the SBAR format, having some decision support tools. They've got a little stop and watch for high risk identification, advanced care planning, and then there's quality improvement tools in there for review of, kind of doing an RCA, a root cause analysis of why the patient had to go back to the hospital. We're switching. Okay. Transitional care intervention. This is advanced practice nurse led, meeting with the patient's pre-discharge with a post-discharge phone call, an active handoff to the PCP, and pre-scheduled follow-up appointments. Results of this showed that the readmission rate of 8.3% for the intervention group versus the control group's 36.8% readmission rate. That's stunning, huge, stunning, gigantic. I mean, almost 30%, just ginormous. To go from almost a 37% readmission rate to an 8% readmission rate for a population, this is something that people need to take a look at. And and I'll give you a little tickler at the end of this. Bobe Barr and Weiss noted that of the 32 hospitals that they surveyed, many of the hospitals were utilizing one of these identified transitional care programs as a base, but customized their programs by combining features of other models to address their specific populations and needs. So the next thing that you see on here is the PAC program, and the PAC program is mine. And I will tell you that I did exactly what Bobe Barr and Weiss did. I took Project Red, and I took a little bit of Project Boost, and I took a little bit of the transitional care intervention, and I smashed it all together and created this PAC program. It's a post-acute transition of care model that's initiated during admission, like the transitional care intervention, focusing on patient and family education throughout the care stay, structured telephone outreach program, just like in Project Red, but I stretched it out through the first 30 days of the post-acute. So our patients got a 48 to 72 hour phone call, go over everything. Then they got weekly phone calls after that, or more frequently if we identified a need for it. And this was for our target population of the ever popular CHF and COPD patients. We reduced our COPD readmissions by 10.45% and our CHF readmissions by 6% during the pilot. And it just got better after that. And it's been implemented at 42 hospitals across the country after that pilot. So this was a great opportunity for us to really take all the best practices that were out there. And again, like Bobe Barr and Weiss said, maybe one of these doesn't work for your population, but pieces of them do, and you can create your own intervention based on your population's needs with all the information and all the evidence-based practices that are out there. Evidence-based practice telephonic information. So we have single call formats, and then we have multiple call formats. Whoops, let me get back to that because that just looks terrible and I can't figure out how to do this now. Give me 5 seconds, guys. Computers. All right, I don't know how to get out of this for a sec. All right, give me 5 seconds. I gotta, hey, I did it, yay. I was trying to move something else out of the way. All right, so Harris, Long, Percy, and Petronas in 2016 noted that using a single call, hi, you've been discharged, let's go over your discharge instructions, and don't forget that your follow-up appointment is on so-and-so date, demonstrated a decrease in 30-day readmissions to 11.25% post-intervention. Another project showed that an immediate discharge call intervention that focused on 3 topics, again, review of the discharge instructions, medication education, and confirmation of the discharge appointment, the post-discharge appointment. That single event demonstration, 22% reduction in readmission for the population of almost 2,000 participants. So that's a pretty decent N size there. Multiple call formats, including programs with a duration of 30 days to 1 year post-discharge. Copeland, Berg, Johnson, and Bauer reported significant decreases for their CHF patients within the first 60 days post-discharge. And after 1 year, there were no significant differences in the pre and post-intervention populations. So it's like after you cut them loose from your program, they're at risk for coming back unless they've really hardwired the changes that you've made. Now, their call content included, of course, patient education, lifestyle changes, diet, medication, and early identification of symptom exacerbation. And Takeda, Taylor, Kahn, Crum, and Underwood in 2012 followed patients for 6 months using a specially trained nurse to provide education, medication reconciliation, and help schedule ongoing appointments. Now, this population experienced a 58% reduction in readmissions because they kept that connection with that medical professional to help them navigate through the system. So is that the power of case management? Oh, yes, I think so. Condition management. Interesting, a pharmacist-driven medication education program to increase understanding and compliance with medication usage. This is specifically for COPD. Look at those results. Readmission reduction for COPD patients from 21.3% pre-intervention to 8.6% post-intervention. And we'll talk more about the power of a pharmacist-driven medication education in my second program today. Cavalier and Sickles developed a checklist for chronic care management education, focusing, of course, on CHF and COPD. And that checklist drives patient education through the inpatient admission to account for all the education that's required for effective diagnosis and condition management. So again, checklist. Pilots use them. Would we go up in a plane if a pilot did not get through their checklist? I would not. Why are we discharging patients from the hospital without checklists being completed? And look at that. The use of a checklist reported reduction in admission for the readmission for the population from 28% down to 17%. And then in 2013, Basur and his group investigated use of that checklist for discharge planning. Checklist. Now, everything that's on the checklist, recommended medications, interventions, counseling topics, the post-acute follow-up appointment was included. The checklist was framed as a physician order sheet to facilitate the execution of the orders in a timely manner. Brilliant, right there. They had, in their study, only 48% or 48 patients received the checklist intervention versus 48 that received the current standard of care. So a very small group, but the results really speak to it. The people that were in the intervention group had decreased in readmission from 20% to 2%, and further use of that over a 6-month period decreased the readmissions in CHF patients from 42% to 23%. Huge. And why not? Why not use a checklist to make sure that you're crossing T's, dotting I's, and making sure that every patient gets a higher standard of care? Care coaches. Pomerantz took a look at using care coaches in a telephonic engagement model. They're registered nurses in their model with experience in behavior modification, and they're supported by an interprofessional care team with their intervention to educate and motivate patients to achieve sustained behavior change. Because we know with a lot of our chronic condition management, there has to be sustained behavior change. You can't keep going to the bar, drinking 7,000 beers and eating all the salty snacks when you have CHF, right? You can't keep smoking when you have COPD. Behavior changes. Through the establishment of one-on-one relationships in a structured, scheduled outreach program over a one-year period with 3,300 patients, this care coach program decreased readmissions in admissions per 1,000 from 44.9 to 23.66. Also, interestingly, a decrease in the average length of stay, decrease in the use of the emergency department, which has also reduced the cost of care for the population. So looking at things, so that's basically from 2009 to 2017. Now, a review of the literature from 2018 through 2022 is not showing anything really new going on in program development, but what we're looking at is more retrospective reviews, economic interpretation of things that have been developed, intended versus unintended consequences. And then people are, taking a look at incorporating social determinants of health under the 21st Century Cures Act, and then making recommendations based on the top 5 most frequently studied and most successful strategies to decrease readmissions. And those include use of home health visits, telephonic follow-up, education, and discharge planning. Surprised? Anybody surprised? Show of hands. Anybody surprised? Nope. So some of the newer things that are coming out are not necessarily hospital-based, okay? A lot of them pharmacy-driven. Zupek notes that 20% of hospital readmissions are related to medication problems. So this model was using pharmacists to conduct hospital discharge visits to review medications and provide education, looked at reducing adverse drug events and medication errors, and making sure that medication adherence was going on through post-discharge calls. And this program achieved a 15% reduction in avoidable readmissions. Cool. Primary care. Hey, we got to get them involved too, right? In 2021, Spivak and their group developed a 12-point primary care readmission avoidance activity list. Why? Because now primary care docs are going to be involved in readmission reduction. Yay. Activities could include the following. They need to receive and review the hospital discharge summary within 72 hours of discharge. Like that. How many primary care physicians don't even know that their patients are in the hospital because they're being taken care of by hospitalists? Medication reconciliations, doing some home visits, having a case manager or a health coach employed embedded in the practice. My favorite right there. Regular follow-up calls and telehealth visits for the first 30 days post-discharge. A health literacy evaluation every time they see the patient because stuff can change. Patient-centered education and culturally tailored care, screenings for social determinants of health, connection to resources for any identified gaps in social determinants of health, incorporating patient-centered care strategies, and implementing shared decision-making models. And their findings were that practices that perform 10 out of 12, you don't even have to do the whole thing. 10 out of 12 of these activities have a significantly lower risk of patient readmission. Is anybody out in CMSNE land surprised? I'm not. So, risks and benefits. Let's talk about that. Years and years and years and years of work put into reducing avoidable readmissions. Yet there wasn't a lot of concern or data available about what the risks and the benefits are. So now we have that data. And some areas of concern that have been identified are the unintended versus the intended effects, throughput versus readmissions. We have competing priorities there, right? Impact of social determinants of health. What's the patient's role in readmission reduction? Because if you're like me for the past 10 or 15 years, you've been saying the exact same thing. Okay, the hospital's doing this. Case management's doing this. The doctors are doing this. We're getting them linked up. Who is this actually happening to and what's their role in this? And then morbidity and mortality concerns as well. So intended versus unintended consequences and effects. So intended, we want to reduce readmissions. We of course want to reduce the penalties. You know, there are penalties in place to draw attention to the issue. And as hospitals, we want to reduce those penalties because we need that money to take care of our patients. Readmissions are publicly reported. So it doesn't make anybody really confident if you are looking at Medicare.gov and your hospital where you go to has a 50% readmission reduction. And it is a quality metric. So it's quality of care. Now, the unintended, heart failure mortality rates increased according to a JAMA study. This does not, however, take advanced condition management issues into consideration. And they state that readmission reduction is not the best indicator of quality of care. And it probably isn't the best, but it's one of them. Throughput versus readmissions. The effective throughput, we all know throughput, the effective movement of patients along the internal continuum of care. And then we have length of stay issues. We've got our DRG payment, we've got GMLOS, we've got all these things that go into the soup of how we manage our patients in the hospital. So Columbia University Business School did a study in 2020 called Should Hospitals Keep Their Patients Longer? 6.6 million Medicare patients were followed. And they were comparing the potential benefits of one additional day in the hospital versus those going to outpatient in terms of reducing readmissions, death rates, and costs. The study found that waiting one more day reduced the mortality risk for pneumonia patients by 22%, reduced the risk of mortality for heart attack patients by 7%, resulted in 5 to 6 times more lives being saved compared with outpatient care, decreased the risk of readmission for severe heart attack patients by over 7%. So their hypothesis is that keeping patients hospitalized for one extra day would help them to reach a higher level of stability and would give doctors and nurses more time to educate them about their post-discharge behavior. So length of stay, throughput, avoiding readmissions, competing, right? Some of the more detailed findings, letting high severity heart failure patients stay in the hospital for one more day decreased their readmission rate by 7%, and keeping all pneumonia patients who have Medicare fee-for-service plans in the hospital for an extra day would save over 19,000 lives every year. Now, if you bump that up against another study that was done by Harvard about, it said, how dangerous is a day in the hospital, where each additional day in the hospital increased the risk of medication errors and pressure ulcers and I forget what the other one was. Risk of hospital-acquired infection. So this is saying that it'll reduce mortality if we keep patients in the hospital for an extra day. But the Harvard study says that our patients who are in the hospital for for every day, it's an incremental risk. It builds upon itself. So we're risking HAIs, we're risking pressure ulcers, and we're risking medication errors versus reducing mortality for pneumonia, heart attack patients, et cetera. So it's a very fine line that we have to figure out. When is the right time to send our patient home? Are they ready to go home? Do they understand everything that we're doing? And are they at risk for all of these other things as well? The ever popular social determinants of health. Case managers have known about social determinants of health forever. And all of a sudden, it's just like this big, gigantic, we have to do something about social determinants of health. And we're all sitting back here going, yes, we've been telling you that. So HRRP programs have resulted in a disproportionate amount of financial penalties to providers that care for vulnerable and low-income populations. Social determinants of health, poverty, disability, housing instability, residents in disadvantaged neighborhoods have been associated with higher readmission rates. Social risk and readmission are closely linked. Do these patients have access to quality care across the continuum? They have a higher incidence of medical risk. Readmissions linked to post-discharge issues. Access to primary care. Here in Illinois, we have expanded Medicaid to, I think, almost 85% of the population. And they go to a managed Medicaid plan, and the managed Medicaid plan, if the patient does not choose a physician within the first 30 days, the managed Medicaid plan chooses their primary care provider. And most of our patients have never seen this primary care provider because that's not the person that they want to go see. But they don't know how to choose their provider in the system, because the packet that they get in the mail from the managed care organization is about that thick, and it's written in a language they just don't understand. Follow-up appointment attendance. Again, back to my lady. I just saw a whole bunch of hospitals or a whole bunch of doctors in the hospital. Why do I need to see another one? Health literacy. We're sending people home with a packet of paper from in their discharge instructions that, suits our needs, because, we have to give them medication education. We have to give them all their follow-up stuff. We have to give them education about their diseases or their comorbidities and, all of their new meds, et cetera, et cetera. And sometimes that packet ends up being a ream of paper. And we're sending that home with them, not knowing, first of all, if they can read to begin with, and can they read at the level that we're sending all this stuff home with, or can they do anything with that information? So health literacy, and we'll talk more about that in my second presentation, really comes into play here when we're talking about reducing readmissions and we're talking about making sure that our patients have everything that they need to be successful. Well, yes, you may have given them a packet of paper and you think, okay, my job's done. I gave them what they needed to be successful. But did you really? Did you explain it to them? Did they reflect it back to you and show you that they can understand it? That's the important part of it. And then, do they have the ability to adhere to those new health regimens that are being recommended for them? Can they access and afford their prescriptions? Some of these prescriptions that they're being put on are very high dollar. And if they're in a managed plan, it might not even be on the formulary for those managed plans. So we have to take that into consideration as well. Whoops, that was weird. So safety net hospitals have a higher readmission rate and versus our more affluent. The little graph in the middle there shows you that, safety net hospitals run a higher risk of penalties than the more affluent hospitals did. So what they did at the HRRP was add social risk factors, or SRFs, to the risk adjustment. And that has been demonstrated to decrease readmissions and the associated penalties for the safety net hospitals. Also, adding the SRF at the patient level ensures that facility performance measures are not just adjusted away. Now, over half of safety net hospitals that received penalties saw those penalties decline. 4 to 7% of the facilities went from having a penalty to having 0 penalties, and it was a $17 million reduction in penalties for safety net hospitals reported by Joint and Maddox in 2019. So we know that the SDOHs have a lot to do with our readmission, and there's not a lot that the hospital is going to be able to do about that in the way of education, et cetera. It's all about connection. It's all about making sure that they have the resources to activate and identifying the gaps in the first place. So this makes sure that the safety net hospitals that are taking care of our most vulnerable and our most at-risk patients aren't penalized out of business, so that there's nobody to help take care of those patients. All right, so the impact of our patient's role. The patient's role in healthcare is still not factored into readmission reduction, okay? Are they being adherent to their treatment plan? Have we considered their health literacy status? Are they engaged and are they activated? There's really no significant research available on this, but we know that we've got to get our patients engaged. We've got to get our patients activated. So how are we going to do that? I leave that question up for conversation in the post-presentation chat. Mortality concerns. CMS's calculations place a higher value of reducing readmissions than on improving mortality rates, according to Castellucci. Mortality rates or mortality costs the hospital 0.2% compared to the maximum 3% readmission penalty. Wadera reports that post-discharge deaths for patients with heart failure were increasing prior to HRRP, and the trend accelerated after HRRP was put into place. It was 7.9% in 2008, up to 9.2% in 2014, reflecting a 16% increase in mortality pre and post HRRP implementation. Mortality rates for post-hospitalization for pneumonia were stable prior to HRRP implementation, but increased after the program began from 7.6 to 8.6. COPD mortality rates were 6.9% pre-HRRP and 6.59 when COPD was added under the conditions for HRRP. But then after that went up to 7.3% for 2016 to 2017. AMI mortality rates, no difference pre and post HRRP. Mortality was concentrated in patients who had not been readmitted as inpatient. However, they note that this population had an increased use of ED visits or observation stays versus an inpatient level of care. So we all know about the whole gaming the system thing, right? Oh, well, if we don't put this patient in inpatient status, it doesn't count as a readmission, right? But please note that it had an impact. Mortality rate was concentrated in patients who had not been readmitted as inpatient, but had been in your ED or been admitted as observation status. So my conclusions, ready? HRRP has been very successful in reducing 30-day hospital readmissions during the first 5 years of the program, especially been a lot of focus, got to do something. Significant case management research and programs have been developed focusing on patient education, patient engagement, and better care transitions. Awesome stuff. And I know there's more out there, so throw it at me. I want to see it. HRRP penalties may compromise safety net hospitals to be able to continue to provide care, which is a great reason why the SRFs were put in place to help save those safety net hospitals. Having worked for several safety net hospitals in my career and going to leadership meetings and listening to the CFO say, yep, I'm not quite sure if we're going to be able to make payroll this week. It's unnerving, but we're there to take care of our patients. Concern over the increasing trend of mortality for the HRRP diagnosis. We all know that it's solely focused on the inpatient level of care. So we know that there's an increase in use of observation level of care, possibly gaming the system, or ED care with an eye to triaging a patient to avoid a readmission. Maybe moving them out into the community with supports that might not be adequate for where they're at right then. Risk adjustment methods need to improve for a better accounting of the social determinants of health factors as well. And those are my references because I'm a really good student. So I'm going to stop sharing. Bye. And I will entertain questions from this awesome group of people.
Thank you so much, Colleen.
My pleasure.
Yeah, there's one comment from Jennifer. She says, perhaps another reason why readmits have not decreased as many hospitals have closed outpatient disease management programs such as CHF, diabetes, self-management programs. Patients do not have access to ongoing support and education. As we know, the benefits of these programs and associated return on investment take years to demonstrate.
You are absolutely right, Jennifer. Matter of fact, a couple of the hospitals that I worked at, they were like, what should we do for readmission reduction, blah, blah, blah. But then they're closing the CHF clinic and then they fired the diabetic educators. It's like, okay, you've now taken away everything that we need to support these patients out in the community, but they're trying to put that onus back on the PCP and the PCP's office. I mean, you're talking about like, PCP's offices, probably 1 or 2 person shows. They don't have the resources to be able to hire dedicated CHF and diabetic educators, et cetera, right? So, I mean, the onus really does fall back to the hospitals as a bigger entity and a community entity to make sure to be able to do that. There have been some here in my area, I'm in Chicago, there have been some efforts by community groups to put management programs for chronic conditions in place, hooked up to like the FQHCs and even some freestanding ones sponsored by community organizations. Not very successful. Again, to your point, they take years to demonstrate their return on investment, but we know in the area of human return on investment that those programs are invaluable.
Second question is from Laura. Has there been any cost analysis for the community-based organization versus hospitalization?
That's a very good question. And I'm going to scribble that down and I'm going to go and do a research project on that right now. I got to read any cost analysis. Keep the questions coming while I write.
All right. And we have a community-based transitions nurse in our community, in our hospital system. And it's wonderful. I mean, it's one person, but she does a great job. So I do like
I
those
think
programs.
a lot of these are actually hospital based. I mean, our PAC program did exactly that. It took the patient, they connected with the patient while the patient was in the hospital. Every day that the patient was in the hospital, our PAC nurse would go and talk with the patient. And we had a schedule of education that happened over a 3 or 4 day length of stay. And then they followed up with them afterwards and were just really connected with them. Now, there is a great community-based, organization here in Chicago, affiliated. I think they're housed out of Rush University Medical Center. Yeah, actually, they just did a presentation for us at our weekend event a couple of weeks ago, and I can get data from her about the impact. I know that their readmission reduction program is incredible and has been in place for about 10 years and shown some great returns. I don't know the cost analysis though. So I will reach out to Bailey and I will get that and I'll provide that to this group so that you can have that information.
All right.
Colleen,
Mhm.
Colleen, it's Doug. Just a question. Are the services aimed at reducing readmissions, whether inpatient or post-acute, reimbursable by Medicare?
Okay, do that again.
If the services are the efforts of people whose main job it is to reduce readmissions, either inpatient or post-acute, reimbursable by Medicare.
Can we charge Medicare for
Can
these?
you charge Medicare for that?
No.
So can the primary care office that, hires a case manager specifically to reduce the readmissions of their primary care patients, can they get funding for that position?
Okay, so that's a yes and a no.
Okay.
Okay, so we can't get funding for the person who's actually doing it. However, under the transitional care model codes, the physician can get paid for it. I have a whole other presentation on that.
Yeah. Let's not go there. Thank you.
But there's three or four different levels that the physician office can bill for TCM. It's like low, medium, high, and then complex. So they can get extra money based on that, and hopefully would use that money to hire staff in to do,
Right.
enhanced care coordination and education, but maybe not.
Great.
All right.
Okay. Thanks.
Have I found any recent research that compares the use of RNs versus the use of non-licensed staff in completing post-discharge calls to the patient? With the nursing shortage and ongoing fiscal considerations, organizations are looking for alternatives, but I'm concerned regarding the quality of care. So a lot of the managed care organizations are doing exactly that. They're using non-licensed staff to kind of vet the call. If it's a call saying, hey, I need transportation, they'll take care of it. If it's a call that says, I need somebody to, find me some community programs, they'll help with that. If it's a call that falls outside of their little box of the things that they can do, then they triage that up to a nurse to be able to triage it further. So you've got a whole group of care coordinators, and the hospital that I work at right now, the health system that I work at right now, we've got an outpatient care coordination unit that has 3 different levels within it. It has a non-clinical level, it has a social work level, and it has a nurse level. So that non-clinical person can take care of transportation, setting up appointments, blah, 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 blah. If it's something related to social determinants of health that the social worker needs to get involved with, they send it over there. If it's a clinical question, medication question, et cetera, they send it over to the nurse.
All right, from Cindy Smith, we are expected to decrease readmissions and keep length of stay to the hospital goal, but the patients are sicker and our expectations unreasonable at times. How can these goals be accomplished, especially for end-of-life patients?
I agree. And that was the whole premise of that slide of throughput and length of stay versus readmissions. It's a mess. We can't do all of it all at once. We're expected to decrease readmissions, and we're expected to keep our length of stay down. We're expected to facilitate throughput and move patients out quickly. And yes, their expectations are absolutely unreasonable. We do have sicker patients, especially if you're at a higher level medical center and they want you to stay at the GMLOS for the, for Medicare for these patients. And it's like, that's not just the only thing they have. That's just what got them here. How can goals be accomplished, especially for end of life patients? I'm gonna step out. I'm not endorsing, I'm not recommending, but let's face it, palliative care and hospice are seriously underutilized. Seriously underutilized. I'll tell you a quick personal story about this. My mother was a nurse for 38 years in the ICU. Okay. Some of you may know this. She was diagnosed with Parkinson's disease. December 2018. Really, I mean, and it was a rapid decline, crash and burn, right? So she went into the hospital for Crohn's exacerbation. She came out, she went to rehab. She failed rehab. Then she went home. And then she ended up back in the hospital 2 or 3 more times. My mother was like the readmission queen for a little bit there because we could not get her under control with her Crohn's. And then the Parkinson's was just totally messing everything up. She begged to go back to rehab, to give it, one more shot. This would have been now her 3rd shot at rehab. So I negotiated with the rehab and they said, all right, yeah, we'll take her one more time. We're going to give her a week. And if she doesn't participate, then we're going to discharge her. So I sat with my mom and I said, here, this is the deal. They're willing to give you one more shot. They're willing, they're going to take you for a week. You've got to participate in the therapy sessions. That was a big problem the previous times that she was there. And I said, but if you don't do this, and if you can't do this, then we're going to start talking about hospice. She had been very, very adamant that she did not want to talk about hospice. She said she wasn't done. And I said, Mom, you know darn well as a nurse that hospice does not mean you're going to die next week. But she wasn't ready to pull that trigger. So that's a huge issue that we need to overcome with our populations, is educating them about what hospice does and how hospice actually can help increase the quality of life. And people who are on hospice have been shown to actually live longer than expected. So Mom failed out of rehab that 3rd time. And she looked at me and she's like, okay, pull the trigger. So we got her on hospice and she did incredibly well on hospice, incredibly well. She loved hospice. She loved the people coming to her house and taking care of her. And they were doing this and she had all these little visitors and she was just in her glory, having a great old time. And, as karma would have it, the hospice nurse was there when she left us. And it was an incredibly awesome experience to be able to go through, because I now have I was a huge true believer in hospice to begin with, because I worked as a hospice aide when I was in nursing school. But having this more personal experience really showed me the value of palliative care and symptom management, and then transitioning into hospice, because it really did make a heck of a difference. Palliative care is not hospice. Palliative care is symptom management. So you can imagine your patients who are coming in and they're sicker like you're expecting. And sometimes their expectations, the patient's expectations are unreasonable. You got to cure me of this disease. It's not a curable disease. If we can explain to them that palliative helps manage your symptoms, and your symptoms are what keep you coming back to the hospital and getting sick, then maybe we can use palliative care as that stepping stone between staying in the hospital, readmitting to the hospital 90 million times at the end of life, versus having the end of life that people really want. And what's their goal for their end of life? Do they want to pass in the hospital, or do they want to pass at home surrounded by their loved ones in a familiar environment? 90% of people want to pass at home.
Yeah. It's a wonderful story. I mean, palliative care, hospice, it's a great program, especially if it's in your hospital. We have one more. I think we have time for one more. June Stark says, what do you think of the benefits of readmission screening by the case manager as part of the inpatient admission process?
Absolutely. There's a couple of really good tools out there. excuse me, the LACE tool has been around forever. But now you've got the hospital score is one of the relatively newer ones as well. And I think there's one also called the patient score. I'm actually working on a book about this subject. See, this is the beginning of the book. And was taking a look at all the different tools that are out there to help us predict risk and, you know, predictive modeling, things like that. They're very valuable because they help give us at least a heads up onto, you know, this could be a problem. We need to address this. You know, maybe it's just a simple act of, hey, you know, tell me how you manage your CHF or your COPD at home, and getting that conversation started.
Yep.
Versus, you know, oh, you need a full readmission reduction program. So
Right. Well, good. Well, I don't see any other questions or comments, but thank you so much. That was wonderful.